Here's something that should concern you. 88% of American adults have at least one marker of metabolic dysfunction, and many have no idea they're building arterial plaque right now, silent blockages forming in the arteries that supply their heart and brain. For decades, we believed arterial plaque was permanent, a one-way street. Once it formed, you were stuck with it. The best you could hope for was slowing it down. But landmark trials over the past 15 years changed that story completely. I'm talking about ASTEROID, GLAGOV, CANTOS, studies that use direct imaging to show something remarkable. Arterial plaque can actually shrink. Today, I'm going to show you 4 evidence-based strategies that reduce arterial plaque, not just slow its growth, actually reduce it. I've analyzed the trials, examined the mechanisms, and I'm going to break down exactly what works, what the numbers show, and how you can apply this. But first, let me be honest about what reduce actually means. When researchers talk about plaque reduction, they're describing 3 different outcomes. Understanding these distinctions matters because they set realistic expectations. First is regression. This means actual volumetric shrinkage. The plaque physically gets smaller. This is possible, but it's the rarest outcome. Second is stabilization. The plaque doesn't necessarily shrink much, but its composition changes dramatically. The dangerous lipid core gets smaller. The protective fibrous cap covering it gets thicker. Calcification becomes denser and more stable. This transformed plaque is far less likely to rupture and cause a heart attack. Stabilization might not sound as exciting as regression, but it saves lives. Third is slowed progression. Instead of growing rapidly, the plaque barely advances or stops growing entirely. This buys you years or decades of protected time. Here's what's remarkable. Even tiny changes in plaque volume translate to massive reductions in cardiovascular events. Research published in JAMA Cardiology analyzed multiple trials and found that each 1% decrease in plaque volume associates with a 19 to 25% reduction in heart attacks and deaths. Let me repeat that because it's critical. Less than 1% shrinkage in plaque, changes you couldn't see with your naked eye, can reduce your risk of dying by nearly a quarter. These modest measurements produce profound clinical benefits. So when I say these strategies reduce plaque, I'm talking about outcomes proven by imaging studies where scientists directly measured arterial walls before and after treatment. This isn't a theory, this is data. Before we dive into solutions, you need to understand what you're fighting. What actually is arterial plaque? Plaque, technically called an atheroma, is a complex structure that builds up inside your artery walls over years and decades. Let me walk you through how it forms, because understanding this process reveals why the 4 strategies I'm about to share actually work. It starts with LDL particles. LDL stands for low-density lipoprotein, and these are the molecular vehicles that carry cholesterol through your bloodstream. Their job is delivering cholesterol to tissues that need it for building cell membranes and producing hormones. Cholesterol itself isn't evil. Your body requires it. The problem begins when LDL particles get trapped in the artery wall. The inner lining of your artery, a delicate single layer of cells called the endothelium, normally acts as a barrier. But when that barrier becomes damaged or dysfunctional, LDL particles slip through and get stuck in the layers underneath. Once trapped, these LDL particles undergo oxidation. Think of this like rusting. Oxygen reacts with the LDL particle, chemically altering it. Your immune system recognizes these oxidized LDL particles as foreign invaders, so your body sends in the cleanup crew. Immune cells called monocytes migrate into the artery wall. Once there, they transform into macrophages, cells specialized in engulfing and destroying threats. These macrophages start consuming the oxidized LDL particles. They're trying to clean up the mess, but here's where things go wrong. Each macrophage can only hold so much cholesterol. As they engorge themselves with oxidized LDL, they transform into what scientists call foam cells. These are bloated, dysfunctional cells packed with cholesterol crystals, literal geometric structures of cholesterol molecules that form inside the cell. These foam cells can't leave the artery wall. They're trapped. And now they're part of the problem rather than the solution. Worse, these foam cells release chemical signals called chemokines. Chemokines are molecular distress flares that recruit more immune cells to the area. More monocytes flood in. They too become macrophages, consume oxidized LDL, transform into foam cells, and release more chemokines. The cycle perpetuates itself. More LDL gets trapped, more immune cells arrive, more foam cells accumulate, the plaque grows. Over years, something even more dangerous virus develops inside the plaque, a necrotic core. This is a mass of dead cells, cholesterol crystals, and cellular debris. It's essentially a toxic sludge at the plaque's center. This necrotic core is covered by a fibrous cap, a layer of structural proteins and smooth muscle cells that separates the thrombogenic core from your flowing blood. Think of this cap as a thin shell protecting your blood from the explosive material inside. The most dangerous plaques, the ones that cause sudden heart attacks, have two characteristics: a large, inflamed necrotic core and a thin, fragile fibrous cap. When that cap ruptures, your blood contacts the thrombogenic core. Clotting proteins activate instantly. A thrombus, a blood clot, forms within seconds, blocking the artery. The heart muscle downstream starves for oxygen. That's a heart attack. This is fundamentally an inflammatory disease, not just a cholesterol storage problem. Yes, cholesterol accumulation drives it, but chronic inflammation sustains it and makes it dangerous. Now, here's the crucial insight. If we understand how plaque forms, we can understand how to reverse it. Reversal requires 4 biological processes working simultaneously. First, you need to reduce the LDL influx. Stop new cholesterol particles from continuously arriving at the plaque site. Second, you need enhanced cholesterol efflux. Another type of particle called HDL, high-density lipoprotein, can interact with the plaque and actually remove cholesterol from those trapped foam cells, carrying it away. Third, you need macrophage egress. The immune cells that migrated into the plaque need to leave. For this to happen, the inflammatory signals keeping them there must stop. Fourth, you need inflammation dampening. The macrophages that remain need to switch from a pro-inflammatory state to an anti-inflammatory state. Instead of recruiting more cells and producing destructive molecules, they begin secreting anti-inflammatory signals and carefully clearing debris without causing collateral damage. When all 4 processes align, remarkable things happen. The lipid core shrinks, the fibrous cap thickens, the plaque stabilizes or even regresses.
The 4 strategies I'm about to show you trigger these exact mechanisms. Let me walk you through them, starting with the one that has the strongest, most direct evidence for actually shrinking plaque. Strategy number 1, aggressive LDL lowering. This is the only strategy with direct, reproducible evidence of volumetric plaque regression in humans. Multiple trials using sophisticated imaging technology have proven this works. Let me show you 2 landmark studies that changed cardiovascular medicine. The first is the ASTEROID trial, published in JAMA in 2006. Researchers enrolled patients with coronary artery disease and gave them rosuvastatin, a high-intensity statin medication at 40 milligrams daily for 24 months. They used a technology called IVUS, intravascular ultrasound. This involves threading a tiny ultrasound probe through a catheter into the coronary arteries. The probe takes detailed images of the artery wall from the inside, allowing researchers to directly measure plaque volume with precision. At baseline, they measured their plaque. After 24 months on high-dose rosuvastatin, they measured again. The results were striking. Patients' LDL cholesterol dropped to an average of 61 milligrams per deciliter. That's significantly lower than typical targets at the time. And the plaque, it actually shrank. Statistically significant regression of coronary atheroma. This was the first major trial to prove you could reverse plaque with medication alone. But another trial took this even further. The GLAGOV trial, published in JAMA in 2016, asked a bold question. What if we drove LDL even lower? Researchers enrolled 968 patients who were already taking statins. They randomized half to also receive evolocumab, a PCSK9 inhibitor, a newer class of medication that dramatically lowers LDL. The other half received placebo injections while continuing their statin. They followed these patients for about 78 weeks, performing serial IVUS imaging at the beginning and end. Here's what happened. In the evolocumab group, LDL cholesterol plummeted to an average of 36.6 milligrams per deciliter. That's extraordinarily low. In the control group, LDL remained around 93 milligrams per deciliter. Now for the imaging results. Researchers measured something called percent atheroma volume. This is the percentage of the artery occupied by plaque. In the evolocumab group, percent atheroma volume decreased by 0.95%. In the placebo group, it actually increased slightly by 0.05%. You might think 0.95%? That's less than 1%. You're right. But remember what I said earlier. Even small volumetric changes produce massive clinical benefits. And here's what's even more remarkable. 64.3% of patients in the evolocumab group showed regression, compared to only 47.3% in the placebo group. The researchers analyzed the data further and found something extraordinary. The benefit correlated linearly with achieved LDL. The lower the LDL, the more plaque regression. There wasn't a threshold where benefit stopped. Every increment lower produced additional plaque reduction. Now let me explain why lowering LDL works at the cellular level. Remember those LDL particles getting trapped in the artery wall and feeding the inflammatory cycle? When you dramatically reduce LDL in the bloodstream, fewer particles are available to enter and get trapped. The influx slows. Meanwhile, existing foam cells, those bloated macrophages full of cholesterol, can now expel their contents. HDL particles facilitate this process through molecular pathways involving proteins called ABCA1 and ABCG1. These proteins act like pumps, moving cholesterol from inside foam cells onto HDL particles, which then carry it away. When the influx of new cholesterol slows and efflux of existing cholesterol accelerates, the lipid core begins to shrink. Smooth muscle cells can deposit structural proteins, the fibrous cap thickens. Calcification occurs, but it becomes dense and stable rather than spotty and inflammatory. A meta-analysis examining the relationship between plaque changes and outcomes found that each 1% decrease in percent atheroma volume associated with a 19 to 25% reduction in major adverse cardiovascular events. That's heart attacks, strokes, and cardiovascular death. So modest imaging changes equal profound clinical protection. Now, what does this mean for you? If you have established coronary artery disease or are at very high risk, aggressive LDL lowering is foundational. Here's the systematic approach. Step 1. Start with high-intensity statin therapy. This means atorvastatin 40 to 80 milligrams daily or rosuvastatin 20 to 40 milligrams daily. These are the doses shown to produce the greatest LDL reductions. Step 2. Measure your LDL cholesterol after 4 to 6 weeks on therapy. If you're at very high risk and your LDL is still above 70 milligrams per deciliter, add ezetimibe. This medication blocks cholesterol absorption in your intestines and typically lowers LDL an additional 15 to 20%. Step 3. If you're still not at goal, discuss PCSK9 inhibitors with your doctor. These include evolocumab and alirocumab. They're injectable medications given every 2 weeks. Yes, they're expensive and not all insurance covers them readily, but the GLAGOV trial proves they produce plaque regression. What's the target? Current guidelines for very high-risk patients recommend LDL below 55 milligrams per deciliter, but GLAGOV suggests that even lower, 30 to 40 milligrams per deciliter, produces more regression. There's another measurement you should know about. APO, which stands for apolipoprotein B. Every LDL particle carries exactly one ApoB protein on its surface. So measuring ApoB tells you the actual number of atherogenic particles in your blood, which is often more accurate than measuring cholesterol concentration alone. Ask your doctor to check ApoB alongside LDL. For very high-risk patients, an ApoB below 80 milligrams per deciliter is often recommended, with some experts suggesting below 60 for regression protocols. Now for safety. Statins are generally well tolerated. The main concerns are muscle symptoms occurring in about 5 to 10% of people and rarely liver enzyme elevations. Your doctor should monitor liver enzymes and check for muscle symptoms. If you develop muscle pain or weakness, report it immediately. PCSK9 inhibitors have excellent safety profiles in trials. The main barriers are cost and the fact that they're injectable. Aggressive LDL lowering is the bedrock of plaque regression. Every other strategy I'm about to discuss works better when LDL is controlled. This isn't optional, it's foundational.
Strategy number 2, targeted anti-inflammatory therapy. Even with perfect LDL control, many people still suffer cardiovascular events. Researchers puzzled over this for years. Why would someone with LDL of 50 still have a heart attack? The answer? Inflammation itself drives plaque vulnerability independent of cholesterol. Remember that inflammatory cascade I described? Foam cells releasing chemokines, recruiting more immune cells, perpetuating the cycle? There's a specific molecular pathway at the center of this axis, the IL-1 beta to IL-6 to CRP axis. IL-1 beta is a powerful inflammatory molecule. When released by activated immune cells in the plaque, it triggers the production of IL-6, another inflammatory signal. IL-6 then stimulates your liver to produce CRP, C-reactive protein, which circulates in your blood and can be measured. High-sensitivity CRP, or HS-CRP, is a blood test that reflects reflects this inflammatory activity. This pathway became a drug target, and a landmark trial proved that blocking it saves lives. The CANTOS trial, published in the New England Journal of Medicine in 2017, was a milestone in cardiovascular medicine. Researchers enrolled 10,061 patients who had suffered a prior heart attack and had persistently elevated hsCRP above 2 milligrams per liter despite being on statin therapy. They randomized these patients to receive canakinumab, which is a monoclonal antibody that specifically blocks IL-1 beta, or placebo. This was a true test of the inflammation hypothesis. After a median follow-up of 3.7 years, canakinumab reduced major adverse cardiovascular events by 15% compared to placebo. And here's the critical part. It did this independent of any change in LDL cholesterol. LDL levels didn't budge. The benefit came purely from reducing inflammation. Imaging sub-studies using PET scans and other techniques showed reduced plaque inflammation in the canakinumab group. The molecular pathway was confirmed. Dampen IL-1 beta and you reduce cardiovascular risk. So why aren't we all taking canakinumab? Two reasons. First, cost. It runs tens of thousands of dollars per year. Second, there was a signal for increased infection. When you suppress part of the immune system, you increased infection vulnerability. The benefit-risk calculation for routine use didn't favor widespread adoption, but CANTOS proved the concept definitively. Inflammation is a modifiable driver of cardiovascular disease. This opened the door for other anti-inflammatory approaches. The most practical one is colchicine. Colchicine is an old medication, originally used for gout. It has broad anti-inflammatory effects through multiple mechanisms. It interferes with inflammatory cell activation and migration. The LODOCO-2 trial tested low-dose colchicine, 0.5 milligrams daily, in patients with chronic coronary disease who were already on optimal medical therapy, including statins. After a median follow-up of 28 months, colchicine reduced ischemic cardiovascular events by 25 to 30% compared to placebo. This was a composite endpoint, including heart attacks, strokes, and cardiovascular death. Imaging sub-studies of colchicine show something interesting. While volumetric plaque regression is modest and inconsistent, colchicine appears to shift plaque composition. Calcification increases, but it's dense, stable calcification, not the spotty, inflammatory kind. Some studies suggest fibers' cap thickness may improve. The overall picture is one of stabilization rather than dramatic shrinkage. Think of it this way. When you reduce LDL, you remove fuel from the fire. Anti-inflammatory therapy dampens the flames directly. You need both. The mechanism works like this. When you reduce IL-1 beta and IL-6, you reduce macrophage activation. Fewer chemokines get released. Fewer immune cells get recruited. The pro-inflammatory macrophages in the plaque switch to an anti-inflammatory phenotype. They begin secreting molecules that actually calm the local environment. This makes plaques less vulnerable. The thin, fragile fibrous cap thickens. The inflamed necrotic core becomes less inflammatory. The likelihood of rupture drops. Now, should you take anti-inflammatory medication? The ideal candidate is someone with established coronary artery disease who has optimized LDL control but still has elevated hsCRP, persistently above 2 milligrams per liter. Colchicine is the most practical option. It's oral, once daily, and available as a generic at relatively low cost. Most doctors use 0.5 milligrams daily. Some start at 0.5 milligrams twice daily and then reduce to once daily if the patient tolerates it well. The main side effects are gastrointestinal, diarrhea, nausea, abdominal discomfort. These occur in a minority of people but can be limiting. Colchicine also requires monitoring of blood counts because it can rarely cause neutropenia, a drop in white blood cells. There are also drug interactions. Colchicine is metabolized by liver enzymes that interact with other common medications like certain statins, antibiotics, and antifungals. Your doctor needs to review your medication list carefully. One critical point: anti-inflammatory therapy is not a replacement for LDL lowering. It's additive. You do both. The trials proving colchicine's benefit were conducted in patients already on statins with well-controlled LDL. The inflammation reduction works synergistically with lipid control. Canakinumab and other biologic anti-inflammatory agents are generally reserved for research settings or highly selected patients in specialized centers due to cost and the need for infection monitoring. But the core principle is validated. Targeting inflammation reduces reduces plaque vulnerability, and saves lives. Strategy number 3, Mediterranean diet and structured exercise. You might assume lifestyle changes are just supportive, something to do in addition to medication. The data completely disagrees with that assumption. Randomized controlled trials show that diet and exercise alone produce measurable plaque regression and significantly reduce cardiovascular events. These aren't minor effects. In some cases, they rival medication. Let me start with diet, specifically the Mediterranean diet. The PREDIMED trial, Prevention with Mediterranean Diet, was a landmark study published in the New England Journal of Medicine. Researchers enrolled 7,447 participants at high cardiovascular risk and randomized them to one of 3 diets: Mediterranean diet supplemented with extra virgin olive oil, Mediterranean diet supplemented with mixed nuts, or a control diet focused on reducing dietary fat. After a median follow-up of 4.8 years, the Mediterranean diet groups had a 30% reduction in major cardiovascular events, heart attack, stroke, and cardiovascular death compared to the control group. But more importantly for our discussion, imaging sub-studies measured carotid intima media thickness. This is the combined thickness of the innermost 2 layers of the artery wall and serves as a measure of atherosclerotic burden. In the Mediterranean diet groups, carotid intima media thickness decreased. The plaque burden shrank. What's in this diet that produces these effects? High amounts of vegetables, fruits, legumes, whole grains, fish, and olive oil. Moderate amounts of poultry, dairy, and if desired, red wine. Low amounts of red meat, processed foods, and refined sugar. The pattern is more important than any single food. You're replacing saturated fats found in red meat, butter, full-fat dairy with unsaturated fats from olive oil, nuts, and fish. You're replacing refined carbohydrates, white bread, white rice, sugary snacks, with fiber-rich whole grains, legumes, and vegetables. The mechanisms are multiple. First, this diet improves your lipid profile. It raises HDL cholesterol, the particles that remove cholesterol from plaques. It lowers triglycerides. It shifts LDL particles toward a larger, less atherogenic pattern. Remember, oxidized LDL is what triggers the inflammatory cascade in the artery wall. Second, it reduces oxidative stress. The polyphenols in olive oil, the antioxidants in colorful vegetables and fruits, the omega-3 fatty acids in fish. These compounds directly reduce oxidative modification of LDL particles. Remember, oxidized LDL is what triggers the inflammatory cascade in the artery wall. Third, it reduces systemic inflammation. Multiple studies show Mediterranean diet adherence correlates with lower levels of hsCRP and other inflammatory markers. Fourth, it improves endothelial function. The endothelium, that single cell layer lining your artery, functions better when exposed to the nutrients in this diet. It produces more nitric oxide, a molecule that dilates blood vessels and protects against atherosclerosis. This isn't about restriction or deprivation. It's about swapping. Instead of butter on your toast, use extra virgin olive oil. Instead of chips as a snack, have a handful of almonds or walnuts. Instead of a sugary dessert, have fresh fruit. Instead of red meat 4 nights a week, have fish twice, legumes twice, poultry once. If you have established plaque, adopting a Mediterranean-style eating pattern isn't optional. It's foundational. Now let's talk about exercise. Meta-analyses examining aerobic exercise consistently show reductions in carotid intima media thickness. The typical effect is 0.01 to 0.02 millimeters over several months. That sounds minuscule, but remember, we're measuring microscopic changes in artery wall thickness. These represent genuine plaque regression at a cellular level. Exercise also shifts plaque composition. Studies using advanced imaging show that exercised plaques become more fibrous, more calcified in the stable sense, and less lipid-rich. But here's the mechanism that's truly fascinating: the shear stress effect. When you exercise, your heart pumps harder and faster. Blood flows through your arteries at much higher velocity. This creates mechanical force called shear stress on the endothelial cells lining your arteries. Here's what happens at a molecular level. That shear stress activates mechanosensors on the endothelial cells, proteins that detect physical force. These sensors trigger a signaling cascade that changes gene expression inside the cell. The endothelial cells begin producing more nitric oxide synthase, the enzyme that generates nitric oxide. Nitric oxide is a vasodilator, meaning it relaxes the smooth muscles surrounding your artery, causing them to widen. This lowers blood pressure long term. Simultaneously, the endothelial cells upregulate anti-inflammatory genes and downregulate pro-inflammatory ones.
They start secreting protective molecules rather than inflammatory ones. So exercise has a paradoxical effect. During the session, your blood pressure temporarily rises and blood flow increases dramatically. But this transient mechanical stress actually reprograms your arteries to be more anti-inflammatory and vasodilatory in the long run. It's like a hormetic stress, a short-term challenge that produces long-term adaptation. Now, what's the practical prescription? The minimum standard is 150 minutes per week of moderate intensity aerobic activity. This means brisk walking, cycling, swimming, anything that raises your heart rate to about 50 to 70% of maximum. Alternatively, 75 minutes per week of vigorous intensity activity like jogging, running, uphill hiking, where you're at 70 to 80% of maximum heart rate. Add resistance training twice a week. This means using weights, resistance bands, or body weight exercises. Resistance training builds muscle mass, which improves insulin sensitivity and metabolic health. Research suggests that combining steady-state cardio with high-intensity interval training may produce the greatest vascular benefits. Interval training involves short bursts of very high intensity followed by recovery periods. For example, sprint for 30 seconds, walk for 90 seconds, repeat 8 times. But here's a critical safety warning. If you have known coronary artery disease, if you've had a heart attack, undergone stenting or bypass surgery, or have significant plaque on imaging, you must undergo a stress test with a medical professional. A stress test evaluates whether your coronary arteries can deliver enough blood to meet the demands of exercise. If you have severe blockages, exercise could be dangerous. Your doctor needs to assess your current capacity and determine what level of exercise is safe. Assuming you're cleared for exercise, start where you are. If you're currently sedentary, begin with 10-minute walks after meals. Build gradually over weeks and months. There's no rush. Consistency over time is what produces the vascular remodeling effects. Strategy number 4, comprehensive risk factor control. Blood pressure, smoking, blood sugar. These might seem like separate health issues, distinct from the plaque discussion. They're not. They're direct, mechanistic drivers of plaque formation, progression, and vulnerability. And controlling them is essential for the other 3 strategies to produce their full benefits. Let me start with blood pressure, because the mechanism here directly affects the artery lining. Your arteries are lined with endothelial cells, a single layer of cells that serves as the barrier between flowing blood and the arterial wall beneath. These cells are exquisitely sensitive to mechanical forces. When blood pressure is chronically elevated, the constant high pressure physically stresses these cells. They respond by changing their gene expression patterns. Specifically, they upregulate genes for inflammatory molecules and downregulate genes for protective molecules. They start secreting more chemokines, the chemical signals that recruit immune cells. They express more adhesion molecules on their surface, proteins that allow circulating immune cells to stick and invade the arterial wall. This transforms the endothelium from a protective barrier into an inflammatory surface that actively facilitates atherosclerosis. Simultaneously, high blood pressure increases oxidative stress within the arterial wall. This promotes oxidation of LDL particles, feeding the inflammatory cycle we discussed earlier. Studies examining the relationship between blood pressure control and plaque changes show a clear correlation. The greatest reductions in blood pressure associate with the greatest reductions in plaque burden. Now, I need to be precise here. This data is correlational, not definitively causal for plaque regression specifically, but the mechanistic pathway is crystal clear, and blood pressure control definitively reduces cardiovascular events in randomized trials. For most people with established plaque, the target is systolic blood pressure, the top number, below 130 millimeters of mercury, and ideally closer to 120. Work with your doctor on this. Medication may be needed initially, especially if your blood pressure is significantly elevated. Lifestyle approaches help too. The Mediterranean diet lowers blood pressure. Exercise lowers blood pressure. Weight loss lowers blood pressure. Reducing sodium intake helps. These interventions compound. Now, smoking. If you smoke, everything I've discussed is dramatically undermined. Smoking accelerates atherosclerosis through multiple mechanisms. It causes direct endothelial dysfunction. The lining cells become damaged and leaky. It increases oxidative stress, promoting oxidation of LDL particles. It activates platelets, making your blood more prone to clotting. It stimulates inflammatory pathways. Longitudinal studies tracking smokers versus non-smokers show starkly different plaque trajectories. Continued smoking drives rapid plaque progression. Cessation slows progression measurably. The benefits of quitting start within weeks. Endothelial function begins to recover. Inflammatory markers start dropping. Within a few years, much of the excess cardiovascular risk attributable to smoking diminishes. If you smoke, quitting is non-negotiable. This is the highest impact
impact intervention you can make. Combination therapy, pharmacologic support with varenicline, bupropion, or nicotine replacement, plus behavioral counseling, produces the highest success rates. This is one situation where medication should be embraced without hesitation. Quitting is that important. Blood sugar control is the third pillar. High blood sugar damages LDL particles through a process called glycation. Glucose molecules attach to the LDL proteins, altering their structure. These glycated LDL particles are more atherogenic. They're more likely to get trapped in the arterial wall, more likely to be oxidized, and more likely to trigger inflammation. Diabetes accelerates atherosclerosis through additional pathways too: increased inflammation, increased oxidative stress, endothelial dysfunction, and changes in blood coagulation. Trials that combined tight glycemic control with aggressive LDL lowering have shown regression of carotid intima media thickness. The combination is synergistic. For most people, the target is a hemoglobin A1C, a measure of average blood sugar over 3 months, below 7%. This should be individualized based on your risk of hypoglycemia and other factors. Certain diabetes medications have cardiovascular benefits beyond glucose lowering. GLP-1 receptor agonists like semaglutide and tirzepatide reduce cardiovascular events in outcome trials. They promote weight loss, which itself is beneficial. SGLT2 inhibitors have similar cardiovascular and kidney protective effects. If you have diabetes and atherosclerosis, discuss these medication classes with your doctor. Weight loss deserves emphasis, even though it's embedded in the lifestyle discussion. The trials showing the most robust plaque regression share a common feature. Participants lost weight. Why does weight loss help? Multiple mechanisms. Excess adipose tissue, body fat, is metabolically active. It secretes inflammatory molecules called adipokines. Losing weight reduces this inflammatory burden. Weight loss lowers blood pressure through multiple pathways. It improves insulin sensitivity, reducing the glycation and metabolic stress I just described. It improves lipid profiles, lowering triglycerides and small dense LDL particles. Even modest weight loss, 5 to 10% of body weight, produces measurable metabolic improvements. For a 200-pound person, that's 10 to 20 pounds. The Mediterranean diet combined with regular exercise naturally promotes gradual, sustainable weight loss. For some people, additional support may be needed. GLP-1 agonists, semaglutide and tirzepatide, are game changers for weight loss and have cardiovascular outcome data showing benefit. These 4 factors, blood pressure, smoking, blood sugar, and weight, aren't separate from the plaque discussion. They're integral. Control them and you create the physiologic environment where LDL lowering, anti-inflammatory therapy, and lifestyle interventions can produce their maximum effect. Here's the critical insight that emerges from analyzing all this data. These strategies aren't alternatives you choose between. They're synergistic interventions that work best when combined. Think about the mechanisms. LDL lowering reduces the substrate. It stops LDL influx and promotes efflux. Anti-inflammatory therapy dampens the inflammatory cascade. Mediterranean diet provides antioxidants that reduce LDL oxidation while improving endothelial function. Exercise creates beneficial shear stress. Blood pressure controls the endothelium. Smoking cessation removes a major inflammatory and oxidative insult. Glycemic control reduces protein glycation. Each mechanism addresses a different part of the atherosclerotic process. When you stack them, the effects compound. Let me give you a concrete example. Imagine a patient with established coronary artery disease. She starts high-intensity statin therapy plus ezetimibe. Her LDL drops to 50 milligrams per deciliter. That's excellent. Now add low-dose colchicine because her hsCRP remains elevated at 3 milligrams per liter. Her inflammatory markers drop. She adopts a Mediterranean diet. Her HDL rises. Her triglycerides fall. Her oxidative stress decreases. She starts a structured exercise program, walking 30 minutes 5 days a week plus resistance training twice weekly. Her endothelial function improves. Beneficial vascular remodeling begins. She works with her doctor to optimize her blood pressure to 118/75. The endothelial inflammatory activation decreases. The compounding effect is profound. Each intervention creates a physiologic environment where the others work better. This is what the clinical trials often miss because they test interventions in isolation. But in real-world practice, comprehensive risk factor modification produces results that exceed the sum of individual parts. But when do you see changes? Biomarkers change quickly. LDL cholesterol drops within 4 to 6 weeks of starting statin therapy, faster if you add a PCSK9 inhibitor. hsCRP decreases within weeks of starting colchicine. Blood pressure pressure improvements from lifestyle changes take a few weeks to manifest fully, but imaging changes, actual structural alterations in the artery wall, take much longer. The GLAGOV trial followed patients for 78 weeks before imaging again. ASTEROID was 24 months. This is the framework for measurable plaque regression on imaging, 12 to 24 months of consistent intervention.
Clinical benefits appear earlier. Event reduction begins within 6 to 12 months in most trials. Your body responds to improved lipids and reduced inflammation before you can see structural changes on imaging. This is a marathon, not a sprint. Consistency over months and years produces dramatic outcomes. How do you monitor progress? Blood work is your primary tool. Every 3 to 6 months, check a lipid panel, total cholesterol, LDL, HDL, triglycerides. Include ApoB if possible. Check HSCRP to track inflammatory status. If you have diabetes, monitor hemoglobin A1C. If you're on a statin, your doctor should periodically check liver enzymes and creatine kinase, a marker of muscle breakdown. For imaging, carotid ultrasound is non-invasive and can track intima media thickness changes over time. A coronary calcium score, a specialized CT scan, establishes your baseline burden of calcified plaque. This is usually done once. Repeat coronary CT angiography is generally reserved for specific clinical indications, not routine monitoring. Track your blood pressure at home. Get a quality home blood pressure monitor and check it regularly, ideally at the same time each day. Keep a log. Monitor your weight. Even better, track body composition if you have access to a DEXA scan or bioelectrical impedance scale, though these have limitations. Assess your exercise capacity. Are you able to walk farther without getting winded? Can you exercise at higher intensity? Improving fitness is itself a proxy for cardiovascular health. Work with your cardiologist or primary care doctor to create a personalized monitoring schedule based on your risk level and the interventions you're using. Now let's talk about some important caveats and safety. First, let's be realistic about the magnitude of regression. When GLAGOV showed a 0.95% decrease in percent atheroma volume, that's less than 1% volumetric reduction. ASTEROID showed similar modest absolute changes. These sound tiny, but here's the perspective that matters. Meta-analyses pooling multiple imaging trials found that each 1% decrease in percent atheroma volume associates with a 19 to 25% reduction in the odds of major adverse cardiovascular events, heart attacks, strokes, cardiovascular death. Modest imaging measurements produce massive clinical protection. Don't get discouraged by small numbers on imaging reports. Those small structural changes translate to dramatic survival benefits across large populations. Also, not all plaque reduction is volumetric. Some plaques don't shrink much, but undergo profound compositional transformation. The lipid core shrinks, the fibrous cap thickens, calcification becomes denser and more stable. That plaque is far less likely to rupture, even if its total volume didn't decrease dramatically. Stabilization is success. Don't fixate solely on regression. Second, individual variation is massive. These trials report average effects across populations. You might respond better than average, or you might respond worse. Genetics play a role. Some people are statin hyperresponders. Their LDL plummets on low doses. Others have genetic variants that make them less responsive and require PCSK9 inhibitors to reach their target. Some people have polymorphisms affecting inflammation. They have persistently high HSCRP despite optimal LDL control. This is why personalization matters. Test, intervene, retest, adjust. Your starting point matters too. Someone with extensive plaque might not achieve complete regression, but can still achieve stabilization and event reduction. Someone with early plaque caught young might achieve more complete reversal. Age, comorbidities, medication tolerance, access to care, ability to adhere to lifestyle changes, all of these factors influence outcome. Work with a healthcare provider who understands these nuances and can tailor a plan to your specific situation. Now let's talk about some safety signals from the medications. PCSK9 inhibitors are generally well tolerated in clinical trials. The main adverse effects are injection site reaction, redness, swelling at the injection site, which are usually mild. There were early theoretical concerns about cognitive effects when LDL goes very low, but large trials haven't confirmed clinically meaningful cognitive impairment. The bigger barriers are cost and the injectable route of administration. Statins have a more complex safety profile. Muscle-related symptoms occur in about 5 to 10% of people. This ranges from mild myalgias, muscle aches, to rare but serious rhabdomyolysis, where muscle breaks down rapidly and can cause kidney damage. If you develop muscle pain, weakness, or dark urine on a statin, contact your doctor immediately. Liver enzyme elevations occur in a small percentage. This is why periodic monitoring is is recommended. Some people report cognitive effects on stat. The data here is mixed. Large trials don't show clear cognitive impairment, but individual experiences vary. Statin intolerance is real for some people. If you truly can't tolerate any statin, PCSK9 inhibitors become even more important, or alternative agents like bempedoic acid can be considered. Colchicine's main side effects are gastrointestinal, diarrhea, nausea, abdominal discomfort. These usually improve over time or with dose reduction. Rare but serious effects include bone marrow suppression, which is why blood count monitoring is necessary. Colchicine also has significant drug interactions, particularly with certain statins, some antibiotics, and antifungal medications. Your doctor must review your complete medication list. There's been a controversial safety signal in some trials suggesting possible increased non-cardiovascular mortality with colchicine, though this hasn't been consistent across studies. The benefit-risk calculation still favors its use in appropriate patients, but it requires informed decision-making. Finally, a note on emerging therapies I haven't covered in detail. You may have heard about nanotherapies targeting macrophages in plaques, IV infusions of reconstituted HDL particles, or other experimental approaches. These are fascinating and may represent future breakthroughs, but they're not ready for clinical use outside research trials. The 4 strategies I've detailed, aggressive LDL lowering, targeted anti-inflammatory therapy, a Mediterranean diet with exercise, and comprehensive risk factor control, are what's available, proven, and actionable today. 15 years ago, the scientific consensus was that arterial plaque was permanent. Once formed, it was irreversible. The best we could hope for was slowing its growth. ASTEROID changed that in 2006. GLAGOV confirmed it in 2016. CANTOS proved inflammation matters in 2017. PREDIMED showed diet works. Dozens of smaller trials filled in the mechanical details. We now have direct imaging evidence, ultrasound images from inside coronary arteries, showing that plaque can regress, stabilize, and become less dangerous. It requires aggressive, comprehensive intervention. Very low LDL cholesterol, below 55, potentially below 40 for maximal benefit. Inflammation control through targeted therapy where appropriate, a Mediterranean diet pattern rich in anti-inflammatory, antioxidant nutrients. Regular structured exercise creates beneficial vascular shear stress. Blood pressure control protects the endothelial barrier. Smoking cessation, glycemic optimization. This isn't easy. It requires lifestyle change, regular monitoring, and persistence over months and years. But the outcomes aren't just imaging measurements. They're fewer heart attacks, fewer strokes, fewer deaths, years or decades of additional healthy life. If you have known arterial plaque or you're at high risk, here are your actionable next steps.
First, talk to your doctor about optimizing your lipid management. Get your LDL and ApoB measured. If you're not on high-intensity statin therapy, discuss starting. If you're on a statin, but LDL is still above 55 or 70 milligrams per deciliter, depending on your risk level, discuss adding ezetimibe. If you're still not at goal, ask about PCSK9 inhibitors. This is the foundation. Everything else builds on this. Second, get your hs-CRP checked. If it's elevated, above 2 milligrams per liter, despite good LDL control, discuss anti-inflammatory therapy with your doctor. Colchicine has the most data and is the most practical option for most people. Third, adopt a Mediterranean eating pattern starting this week. You don't need perfection. Start with the swaps I mentioned. Olive oil instead of butter, fish twice a week, more vegetables, more legumes, whole grains instead of refined, nuts as snacks, fruit for dessert. Each meal doesn't have to be perfect. The overall pattern over weeks and months is what matters. Fourth, if you're not currently exercising and you have known coronary disease, schedule a stress test with your doctor. Once cleared, start a graduated exercise program. Begin where you are. If that's 10-minute walks, that's fine. Build gradually. Aim for that 150 minutes per week moderate intensity target over time. Add resistance training twice weekly. Fifth, address your other risk factors. Get your blood pressure checked. If it's elevated, work with your doctor on a treatment plan. If you smoke, quit. Use every available resource, medication, counseling, whatever it takes. If you have diabetes or prediabetes, optimize your blood sugar control. Sixth, create a monitoring schedule with your healthcare team. Regular lipid panels, blood pressure tracking, medication safety monitoring, adherence check-in. Adjust the plan based on your response. This is comprehensive risk factor modification. It's intensive, but it's what the evidence shows actually works.
risks. One final point. This is educational content based on clinical trial evidence and established medical science. I've cited the landmark trials: ASTEROID, GLAGOV, CANTOS, PREDIMED, LODOCO2. The mechanisms I've described are from peer-reviewed research. But this is not personal medical advice. Every person's situation is unique. Your specific plaque burden, your comorbidities, your medication tolerances, your access to care, your ability to implement lifestyle changes. Work with your healthcare provider to create a plan tailored specifically to you. Arterial plaque isn't permanent. It's dynamic. With the right interventions, it can regress, stabilize, and become dramatically less dangerous. The science is clear. The tools are available. Now it's about implementation. Your arteries can heal. Let's make it happen.